Hello, my name is Dr. Athena Ramos, and I'm an assistant professor in the Department of Health Promotion in the College of Public Health at the University of Nebraska Medical Center. I have almost 20 years of experience in working with communities to try to find solutions to public health concerns. I have three primary research interests. One, occupational safety and health of vulnerable workers like farm workers. Two, immigrant integration in rural or smaller communities. And three, community well-being and all that encompasses, from health promotion programs, health education programs, to creating policies that can improve or foster health and well-being. Today, I'm going to talk to you about some work that we've been doing with a Maya community organization here in Omaha, Nebraska. I will share with you some background information about the Maya, and then we'll spend some time talking about the health initiatives that have been going on with the community, including a health assessment study and a family-based program called Familia, Adelante. And finally, we'll talk about some of the key ideas for adapting and tailoring interventions with communities. Although many people think of the Maya as a pre-colonial civilization or a historic civilization, the Maya are still with us today. On the slide, you'll see two maps. On the left, you'll see the map of the traditional Maya territory in pre-colonial times. And on the right, you'll see the traditional territory that is divided up by the borders of contemporary states. The Maya territory includes what is southern Mexico, all of Guatemala, all of Belize, and parts of Honduras and El Salvador. It's estimated that there's about 10 million Maya living on the traditional territory still today, and about 1 million Maya living in the United States. 1 million Maya in the United States would actually make the Maya the largest indigenous group in the United States, although they are federally not recognized. The doctrine of discovery is a 15th century Christian principle, and it's the root of discrimination and marginalization of indigenous peoples today. It promoted the authority of land acquisitions and dehumanized indigenous peoples all around the world. It allowed people, colonizers, to subjugate, to dominate, and to exploit indigenous peoples for their land and for their resources. This doctrine of discovery is still evident today with the experience of the contemporary Maya, who in Guatemala experienced violence almost at genocidal levels between 1960 and 1996. This violence forced many of the Maya to flee their homelands for the safety and security of their families. This is what led many Maya to the United States. In 2007, the United Nations Declaration on the Rights of Indigenous Peoples was adopted by 144 countries. This declaration established a universal framework of minimum standards for their survival, for the dignity, and for the well-being of indigenous peoples. It also elaborated on human rights standards and fundamental freedoms that apply to indigenous peoples. What you see on the slide here is Article 24, which focused on the health of indigenous peoples. It states that indigenous peoples have the right to their traditional medicines and to maintain their health practices, including the conservation of their vital medicinal plants, animals, and minerals. Indigenous individuals also have the right to access, without discrimination, to all social and health services. Further, it states that indigenous individuals have an equal right to the enjoyment of the highest attainable standard of health, both physical and mental health, and that states shall take the necessary steps with a view to achieving progressively the full realization of this right. What this means is that as a country, we have a duty to promote the health, well-being, and access to appropriate health services for all indigenous peoples. If we're serious about addressing the health and well-being of indigenous peoples, including the Maya, then we must move away from the dehumanization and move towards the recognition and the dismantling of the doctrine of discovery and the implementation and full realization of the United Nations Declaration on the Rights of Indigenous Peoples. Without moving towards these 2 points or in this direction, what we'll have is just another manifestation of forced assimilation of Indigenous peoples. Let's move on to now spend some time to talk specifically about some of the health issues that the Maya face. The Maya face a number of challenges to access and to the provision of appropriate care. From the outside, there's oftentimes a failure to distinguish between Latinos and Maya. They're not one and the same. And although the Maya may live in some of the contemporary states in Latin America or have immigrated from those countries, their culture is quite different than that of Latinos. From the inside, sometimes Maya feel like they can't identify as Indigenous because of the prejudice and discrimination that they may experience. Sometimes it's just easier to pass than to try to explain to people who or how they identify. And further, there's sometimes a sense of inferiority, which is very common within Latin America to say, oh, pobres indios, oh, those poor Indians. And that gets embodied into the lived experience of the Maya. There's also a mistrust or a lack of trust between the Maya and people in positions of authority. As you can imagine, with the history of colonization, with the history of genocide and such violence, that this would be a difficult thing for people to overcome. Many Maya have low levels of literacy and comprehension, both in English and Spanish, which are the common languages within the United States and within the US healthcare system. There's many different Mayan languages. In fact, there's over 20 Mayan languages. The Maya are divided by language. And so trying to find an interpreter or somebody who can translate materials into the Mayan languages can be quite challenging. This also makes it difficult for healthcare providers to get an accurate health history of an individual and of their families. Many times immigrants and Mayan immigrants in particular have low levels of health literacy, and they're unfamiliar with the US healthcare system and how to go about accessing different services. Maya also have different definitions of what is health and understandings and etiologies of disease. And further, there's lots of structural barriers like the cost of healthcare or the ability to access healthcare insurance, which can also present major challenges for people to actually get into care. One of the biggest health challenges that the Maya face is trauma. Trauma can be cumulative and multi-layered. There's different types of trauma. For example, there's cultural trauma, which is an attack on the fabric of a society which affects the essence of a community and its members. There's historical trauma, which is a cumulative exposure to traumatic events that affect an individual and continues to affect subsequent generations. There's also intergenerational trauma, which is when the trauma is not resolved and subsequently is internalized and passed on from one generation to the next. All of these types of trauma are present within the Maya. Their trauma comes from the history of oppression and genocide and exile. This is an example of historical trauma. There's severe poverty. There's a cultural and linguistic differences, which is related to the cultural trauma that they experience. And there's also a loss of that indigenous identity, which is intergenerational and also cultural trauma. Based on a study in Southeast Florida of 102 adults who identified as Mayas from Guatemala, they found that women had higher levels of trauma than did men, and that among women, this was related and associated with depression. And trauma was also a risk factor for alcohol dependence, particularly among men. Science is now coming around to the experience that people have. And there's new criteria in the DSM-5, which is the Diagnostic Statistical Manual, which is used for diagnosing behavioral health concerns. And there's actually now a category for traumatic events, which includes indirect associations with violence and witnessing violence. So we know that there's cumulative trauma, and that this can be a very toxic combination of social, of psychological, of environmental, cultural, and biological stressors among populations, particularly among Maya, which places them at a higher risk for both mental and physical disorders that can lead to serious health consequences over the long run. Culture can be an asset to improving health and well-being. And if we can go back to the roots, we can find those inherent strengths in the individual, family, and community. The Maya worldview and the culture and their identity shapes their perspective on health, help-seeking, and well-being. Maya healing and Maya medicine addresses more than just physical health concerns. It also addresses social and moral aspects and provides guidance through story, through prayer, and through rituals. But it's up to us as public health practitioners to understand and figure out ways that we can incorporate culture to better promote the health and well-being of the populations that we're trying to serve. The Maya worldview is based on a number of core principles. First, it's based on the idea of duality, in that every human being has both a physical and a spiritual side. It's also based on the complementarity, meaning that there's a relationship between the person and the universe, and that one supports the other. Third, there's the idea of cyclicity, in that every decision, every action, every event is really a consequence of the things that came before it. And there's the idea of reciprocity, in that there's an exchange between the people and the spiritual world. There's also a belief in harmony and equilibrium, and the fact that the people are just one part of a much greater world. These principles of Maya worldview are epitomized in the circle shown in this slide. It shows people coming together in prayer and in faith for the greater good of the collective. You see, the Maya feel very strongly about the importance of the collective group. So it's not just about me as an individual doing the best that I can for me and my family. It's also about me as an individual doing the best that I can for my community, and my community doing the best that they can for me. Over the past 10 years, I have been involved with a local Maya community-based organization called Comunidad Maya Pishan Ishin. I currently serve on the board of directors for this organization, and our mission is to improve the health and well-being of the Maya people through community development strategies, both here in Omaha and in the Canjobal territory in Guatemala, and making sure that what we're doing is consistent with the social organization of the community itself. Our vision is to ensure the prosperity and to be able to contribute to the economic, social, and cultural prosperity of the community. Comunidad Maya Pishan Ishin originated in 2007 with a Maya Catholic prayer group, but we obtained our nonprofit status in 2012. We now have programming that focuses on health. In fact, we have a whole Maya health initiative, which includes a Maya health assessment study, a Maya interpreters network, the Indigenous Peoples Health Fair, and health and wellness programming throughout the year for both youth and adults, and our Familia Adelante program. All of the programs that are offered through the organization are culturally and linguistically consistent with the Maya worldview. First, I'd like to talk a little bit about the Maya Health Needs Assessment Study. This is a collaboration between Comunidad Maya Pishan Ishin, Creighton University, and the University of Nebraska Medical Center. Our goal is to be able to reduce disparities in health and healthcare services that the Maya experience. So we developed a three-phase study. This first phase of the study consisted of 50 open-ended, unstructured interviews with members of the community using convenient sampling methods. The second phase of the study built on the first phase and used semi-structured interviews with community members to try to dig in deeper to some of the issues that were highlighted in phase one. And the third phase is going to consist of 200 structured questionnaires or surveys that will be conducted with the community specific to various health issues that we'd like to learn more about. Some of the preliminary findings from phase 1 and from phase 2 of the study include that there's high levels of tension and of stress, particularly among the people who live in close proximity to one another. There's also major health issues like domestic violence, trauma from the war, substance use, both alcohol and drugs. There's issues related to occupational safety and health, particularly for those who work within the meatpacking industry and having lots of injuries related with repetitive movements. There's obesity issues, diabetes, and cholesterol issues that people identified. Some of the positive changes, though, that people noted were related to the economic opportunity that individuals have when they arrive to the United States, and also to the quality of healthcare services that they have been able to find in the area. Some of the negative changes, though, are related to acculturative stress. As you can imagine, coming from one country to a new country is a difficult experience, particularly if you're coming without authorization or as an undocumented individual, and you don't speak either English or Spanish, that are the primary languages. And so you're linguistically isolated, you're culturally isolated, and that can make it a difficult transition for people. So these are some of the needs that have been identified through the Health Needs Assessment Study. So now we've spent some time talking about the background and talking about some of the needs that the Maya community has. I'd like to turn our attention now to thinking about some of the solutions and the interventions and what we can do to help improve and foster health and well-being among this population. Health promotion and programming should account for a number of factors. For example, it should account for language and culture and educational level and acculturation status of the individual participants. Plus, it should also account for the context that the participants are in. These interventions and these programs should try to link different levels together. For example, the individual level and the interpersonal level, or linking between individuals and community structures, or linking between all of those and the policy level. So trying to hit as many different levels of intervention can be a good strategy for trying to create a more comprehensive approach to addressing the health issues at hand. Sometimes, though, when we're developing a program or an intervention, there has to be some adaptation, particularly if you're using an evidence-based intervention. They may not have been designed for the population that you're working with, or there may be some language issues or cultural factors that make that intervention maybe not work quite as well. And so you may think about adapting or tailoring that particular intervention. First, before you make any changes, though, you would first need to think about what are the core components of that intervention. So what are the things that make that program work? Those are the things that are called core components. And so if you change those, then you lose the fidelity to the program. And implementing the program without those is not actually implementing that program. So you couldn't likely expect the same results from changing the intervention and maybe not doing those components to when you would actually do those components and maybe make some small tweaks here or there to make the intervention fit with the population group better. Some main areas for adaptation may include the procedure. So thinking about the time, the location, the recruitment strategies, the delivering and the staffing of the particular intervention. You may also think about the dosage and how many sessions are necessary to get the result that you need, or how long are the sessions to be able to get the point across with participants. You may think about the content of the intervention and what about adding or removing specific sessions. You may think about the participants and targeting different population groups. And finally, you may do adaptations related to cultural relevance and trying to make the intervention more appropriate for the community that you're trying to serve. So there's 5 potential areas for adaptation: procedure, dosage, content, participants, and cultural relevance. But before you make any changes, again, it's important to think about what are the core elements that have to be maintained. Adapted interventions are a way for us to show respect for the community and for its diverse culture, values, and identities. It's a way for us to be able to better connect with the community. It might also increase the relevance of what we're doing in the minds of community members and decrease some of the resistance that you may face in trying to start a health promotion program. We know that by adapting interventions, we can also increase the engagement of community members and the support for the intervention, and hopefully improve the chances for success of the intervention. There are some types of adaptations which are safe and encouraged to be made. For example, trying to make the program a better fit for the community. So maybe changing the language of delivery. That we would call a green light. Give that the green light, because that one is pretty easy to do. The next would be one that you should use more caution with. So for example, if you're adding or changing a lesson to a standard program. For this, you might want to engage somebody who has some expertise with cultural adaptation. And of course, then there's that red area, which are the adaptations which are unsafe and should be avoided. So for example, if you take away any of the lessons that are part of the standard program, those are things that you really need to think about, because they may compromise the validity and the effect of the program that you're intending with the community. 17, I worked with the Comunidad Maya Pishan Ishin to put in an application to the National Network to Eliminate Disparities in Behavioral Health, also known as the NED. The application was for us to bring a team to be trained in the Familia Adelante program, which is a family strengthening risk reduction program. And we did this because of the conversations that we had had with many of the community members, and also because of the results of the Maya Health Assessment Study, which showed that there were some serious issues related with stress, with alcoholism and substance abuse, and related to cultural pride among Maya community members. These are things that the Familia Adelante program was developed to address. In our application, we described developing a team that consisted of both youth and adult facilitators for the program. In the slide, you can see a photo of our team. This is us in New Mexico, because we were actually selected for the NED Learn and got trained in the Familia Adelante program. The Familia Adelante program is a family-oriented prevention and early intervention program that's designed to address the unique needs and risk factors that are common among Latino families. It focuses on cultural-related factors such as acculturation and the gap of acculturation between parents and children. It also discusses immigration-related stress, discrimination, and cultural conflict. The program not only addresses risk factors, though, it also addresses some of the resilience factors and includes some cultural values like familism, or the importance of the family unit, the idea of respect, the cultural pride, and the collective structure, which is common within many Latino communities and Latino cultures. The program itself consists of 12 sessions, which are 90 minutes each. There are concurrent sessions for parents and for youth. So they happen at the same time, but they're in different locations. So I'll have a parent group in one room and a youth group in the other room. The program itself has been developed in English and in Spanish, and what they found is that there's significant improvements in among the youth in terms of their attachment to their family and their communication with both parents and peers. There's also significant improvements in youth recognizing some of the dangers of alcohol, tobacco, and other drug use. And there's been significant improvements in knowledge related with drug use as well. This program is designed to reduce cultural related factors, not to be a clinical intervention program. So we're not doing any formal counseling or anything like that with families. It's more set up like a facilitated discussion to talk about what are some of the best practices in terms of parenting, and on the youth side, to engage youth in a number of activities that help them to think through stress and how to manage stress and think of some more positive ways of coping with stress. After our team completed the training in New Mexico, we worked diligently with the program developer over the next 4 months and completed a series of online trainings to help support our implementation of the program. We launched the program in the fall of 2017. Here on this slide, you can see the flyer that was developed for that original cohort of the program. You'll notice some unique things. First, we used cultural images. This is actually a drawing that was developed by one of the youth facilitators for the program, which is based off the Popol Vuh, which is the spiritual book that the Maya follow. You'll also notice that there's some strange letters at the top of the flyer, and this is because we actually changed the name of the program into Kanhobal, which was the Maya language that the community here speaks. So you'll notice that the title is in the language of the Maya, and then we put the Spanish language translation of the name below. We had to change the actual name of the program, not just into Canjobal, but actually change the name of the program from Familia, Adelante, or Family Forward, into this saying that says that everybody has to get up together so that nobody stays behind. We did this because within the Maya culture, the idea of one person or one family moving forward is without the rest is not an acceptable. It doesn't really jive with the culture. And so we took the saying again from the Popol Vuh, from that spiritual book, about everybody, that the people, that the whole community is moving forward together. So we felt like this was an important type of adaptation to make in order to make the program more relevant for this community. We made a number of other adaptations to the program in consultation with the program developer. First, in terms of the recruitment, we felt like it was important to have the approval of the Cultural Governance Committee. So this is a group of people who represent the Maya community and ensures that all of the activities of the organization adhere to the Maya worldview. The committee did give us the approval, and they allowed us to recruit families for this program. So we did this differently than what is typically done for the program. Typically, with this program, they accept referrals from schools or from juvenile justice entities and places like that for families and for youth to be in the program. We didn't do that, however. We actually reached out directly to our families and had one-on-one conversations with the families about the program itself. So the Maya facilitators of our team, so there was 3 Maya who were part of our team and 2 of us from the university. The Maya facilitators actually did this outreach with the families. And so they spent a lot of one-on-one time talking about the program and the potential benefits of the program to the families. We also made an adaptation to the implementation language. So I mentioned that the program was available in English and Spanish. However, with the Maya adult community members, the program needed to be in Canjobal. And so we actually implemented the program in Canjobal for the adults, for the parents and caregivers. For the youth, we thought originally Spanish would be the language to implement for the young people. But we learned after the first session that most of the young people were more comfortable in English, and so we switched the language of implementation to English for the youth. So we ended up running the parent group in Canjobal, the youth group in English. We also added in some information and a lesson on Maya-specific cultural history and cultural pride. So that was primarily for the adult group. The youth, they also talked about some of the things that they enjoyed of Maya culture, but it wasn't a specific focus of the youth component. We also changed the typical program location. So usually programs like this are held at community locations. But in our case, in consultation with the Comunidad Maya Pishan Ishim and the Cultural Governance Committee, they felt like it was important for this program to be hosted on campus at the university. It was a way for them to try to expose families to a higher education institution and allow them to experience a college campus and what it's like, so it isn't so scary when their kids want to go to college. And so the program was actually held in our building at the College of Public Health. We made a number of adaptations related to the procedures, to the participants, and to improve the cultural relevance of the program. We also added in a lesson on cultural pride, and so we changed the content slightly without removing any of the other content. So some of the results that we saw from the program were that parents and caregivers were very satisfied with the program, and they were really excited to learn more about some positive parenting practices and how to give consequences, both positive and negative consequences, to their young people. They also talked about how they were better able to talk about their feelings and their emotions and stress. The adult participants also mentioned that one of the most beneficial things of the program was that they learned more about their own history, and they had a greater sense of pride in being able to identify as Maya. Parents also said that they noticed some positive behaviors in their kids. And so they said they would also recommend the program to other parents. The youth told us that they had learned more about substance use, so about alcohol, tobacco, and other drugs, and that they had more confidence in their own abilities. This program was successful with the families who participated. They really enjoyed the program and felt like it was beneficial. We've also had a number of other positive benefits from this program that have come from the collaboration between Comunidad Maya Pishan Ishim and the university. For example, locally, the South Omaha Neighborhood Alliance named this program the Project of Merit. We were able to develop a poster presentation at a conference called Cambio de Colores, which is a regional event that promotes the integration of newcomers to the Midwest. And we were able to share the story of what we've done with Familia Adelante. Both the executive director of Comunidad Maya Pishan Ishim and I were invited by the Substance Abuse and Mental Health Services Administration, or SAMHSA, to come and speak about our adaptations with the program during the National Hispanic Heritage Month. So we got to actually go out to Washington, D.C. and talk about the program, which was actually a really great opportunity because SAMHSA is actually the group that funds the national network to eliminate disparities in behavioral health. So they were part of the people who selected our group to participate in the original training. And so they wanted to hear about the results that we've had with our unique implementation. We have also applied and been the recipient of additional grant funding to support the continuation of the program. And recently, our College of Public Health was awarded a Community Engagement Award from the Association of Schools and Programs of Public Health, where they noted the Comunidad Maya Pishan Ishim collaboration and the Familia Adelante program as one of the successes. There are a number of components to successful campus and community collaborations. On this slide, you'll see 10 of those components highlighted based off the research that has been conducted and best practices in communities. I want to give you a couple of examples of how we've actually put these components into practice. So first, both the executive director of the Comunidad Maya Pishan Ishim and myself, we are co-leaders of the Familia Adelante initiative, and we've been working together for the past 10 years. We've collaborated on a number of different projects, so this wasn't a first-time ask for me to come to him and say, hey, would you do this? But it was built over time through a relationship that's based on trust. We share power between both the community team and the university team. So all of our decisions are made together in consultation with one another. Nobody has say over another group. And our team communicates frequently. We actually have a process for sharing documents. We've got a Google Drive that we share documents, and we're providing, from the university side, we're providing ongoing training for the facilitators from the Maya community for this program. We have regular meetings, and we talk about what needs to be done, what are the skills that need to be developed, and what are some potential research opportunities with this program and with other health initiatives within the community. The Comunidad Maya Pishan Ishim and I co-wrote the application for the Familia Adelante training. So I didn't write it by myself. Again, this was a collaborative effort to write the application. And I think the most important thing to note is that our relationship is not just about a program. It's really about a genuine interest to improve the health and well-being of the Maya people here in the community. And because of this, I was invited to actually serve on the board of directors. They've recognized my commitment and my dedication to the community, and they have invited me to serve in this special leadership position with them. I hope you've been able to identify with some of the discussion points from today's presentation. Now I'd like for you to take a couple of moments and to reflect on what you've learned through this presentation and what you might do to engage other Indigenous groups in your work. How could you use and integrate some of these principles of culture to promote the health and well-being of your population of interest? And finally, it would be important for you to think about how would you culturally adapt or tailor an evidence-based intervention that you're passionate about. What are the types of adaptations that you might make, and why would you do those? And how could you ensure fidelity to the program? I'm glad we had the chance to talk a little bit more about the Maya as an Indigenous people from the Americas, and to think about their background, their history, their experience, their culture, and how those things impact health and well-being of a community. We got to talk a little bit about a collaboration that we have with the Comunidad Maya Pishan Ishim here locally and the Maya Health Initiative. And finally, we talked about some important points regarding cultural adaptation and tailoring of evidence-based programs using the example of the Familia Adelante program. I hope this was a beneficial learning opportunity for you. On this slide, you'll see my contact information. Please feel free to reach out to me if you have any questions about what we've been doing with the Maya community together or about the adaptation of programs. I'm happy to be a resource for you as you move forward in your health careers.